cerebral circulation. When one artery is less dominant, the other will be taking up the supply.
So you can get both the shoulder weakness, arm weakness, and hand weakness. Everything is possible.
Everything is possible because depending upon which anticonvulsants, which area is affected.
Okay.
You can have extensive element finding in antispasmodic artery. Next week, I will share the case.
Okay, sir.
Okay. Okay. Any questions? Shall we go to the next one? Okay. This is a story of a story of a 13-year-old girl. She noticed difficulty in elevating her right arm for the last 4 years. That's the only complaint by which the mother had brought the child to me. But on examination, caleness are all normal. But she had weakness of the right deltoid. Very tricky case. Left was normal. See, right deltoid is weak. Then come to the rest of the examination. Biceps was weak on the right side, left normal. So deltoid was weak, biceps was weak, triceps was normal. External rotation was weak on the right, normal on the left side.
That is good.
Internal rotators were normal. Wrist extension was weak on the left side. Other was more weak on the right side. Here, wrist extension, finger extension is more weak on the left side, not on the right side. The finger extension is weak on the left. Finger flexion normal bilaterally.
That is good.
Long finger flexors were all normal. Intrusive mildly weak. But left side you cannot be difficult because that finger dropped. But not keeping it on the floor, it appeared almost normal, not much of a weakness. Mild weakness is there.
Very good. That is weak.
That is weak on the right side. That's also weak. Slightly more weak on the right compared to the left. Prominence is slightly positive on the right, not on the left side.
Thumb support கொடுக்காத.
So, very funny presentation. Right upper limb proximal muscle more weak. Left recession finger is more weak. Small muscle slightly more weak on the right. And looking at this thing, trapezius is normal. Unable to because of deltoid weakness. And checking the serratus anterior is weak on the right side. It's weak on the right side. Onwards was normal. And he's got a contracture of the finger. See, the finger flexors were contracture. So I cannot fully extend on the left side I could extend.
It is coming up to this level.
That is got a contraction on the right side. Lower limb tone normal or hypertonia. Normal. Beaver's sign was positive. Hip flexion was weak bilaterally, more on the right side. Left side normal, right side was weak. That is normal. Knee extension normal bilaterally. Hip abduction normal. Adduction normal. hip extension was weak on the right side, not on the left side. I can easily overcome that, not on the left side.
അത് മടക്കിപ്പിട്ട് നൂർക്കാൻ സമ്മതിക്കരുത്, മനസ്സിലായില്ലേ?
Hamstrings were
അത്
normal.
തന്നെ മിടുക്കി. അതേപോലെ ഇതിനകത്തോട്ട് പിടിച്ച് മതി വിട്ടോ.
Dorsiflexion was weak bilaterally.
നല്ല സമ്മതിക്കല്ലേ?
AHL was weak.
മുള്ളോട്ട് പിടി.
തള്ളവിരല് മാത്രം.
ഇത് മുള്ളോട്ട് പിടി.
Let me more weak on the left side. Plantar flexion normal. You can see the mild claw feet deformity on the feet and the lower limb, which I'll show you later on. Reflexes, biceps bilaterally decreased or absent. So also supinator decreased. Left triceps was very elicitable. Right was sluggish, just elicitable. Abdominal flexion intact.
ഞാൻ പറയുമ്പോൾ കൈ മുറുക്കി പിടിക്കേ. കൈ മുറുക്കി
Right knee jack was absent. Left was elicitable. Just elicitable.
ആ ഒന്നൂടെ മുറുക്കി പിടിച്ചേ. മതി മതി മതി.
Right angle absent.
മുറുക്കി പിടിച്ചേ കൈ. മുറുക്കി
Left
പിടിച്ചേ.
was elicitable normally.
മുറുക്കി പിടിച്ച മോളെ.
Checked again. Right was absent.
ശരിക്കും ഇതെല്ലാം വ്യത്യാസമില്ലല്ലോ.
Sensations were all normal.
ഇതോ ഇതോ ഇത് അറിയാലോ ഇല്ലേ? ഇപ്പോഴേ ഇപ്പോഴേ ശരി മോളെ എഴുന്നേറ്റ്.
He has got hip flexion weakened, tongue goes into hyperextension.
എഴുന്നേറ്റ്
He goes into hyperextension.
മുറുക്കി പിടിച്ചേ.
EDB was not hyper, but you can find the claw feet deformity bilateral.
ഇറുക്കി പിടിക്കേ. എൻ്റെ ഇറുക്കി പിടിച്ചേ.
Weakness of the intrinsic muscle to the muscles. Again, EDB was normal, but claw feet deformity.
ഇറുക്കി പിടിച്ചേ. ഇവിടെ
Gait, he has got a bilateral step-page gait.
ഇന്നലെ നടന്നത്
There is no waddling. She couldn't walk on heel, but she could walk on toes. Plantar flexion was normal. She could get her from the low laying stool, and hip, the sternal bug was
ഇനിയും ഇടതുകാല് പൊക്കിക്കേ മോളെ. ശരി മതി. നീ വലതുകാല് പൊക്കിക്കേ. പൊക്കിക്കൊണ്ടേ പൊക്കിക്കേ.
on examination. Hale's normal, motor neck muscles normal. Weakness of right serratus anterior. Right upper limb, weakness of right deltoid, biceps and external rotators. Triceps is normal. Wrist flexion extension normal. There is contraction of the finger flexes on the right side. And weakness of all small muscles of the right hand, mainly interosseous and traumas sensor positive. That is on the right side. Left upper limb deltoid normal, biceps scori weakness, triceps normal, but weakness of the wrist extensions and finger extensions just not there on the right side. This was weak on the left side. Other muscles were normal. Small muscles scori mild weakness. Weaver sign positive, lower limb weakness of both hip flexors, right more than the left. Weakness of right hip extensor, left normal. See, in fact, hip flexion is mainly on the right side, mild weakness only on the left side. Hip abductors, adductors normal, knee extension flexors normal. Dorsiflexion of both angles weak, plantar flexion normal, both EHL weak bilaterally, claw feet deformed bilaterally, can walk on toes, not on heel. Could get up from low stool. TTR, both bisupinate absent bilaterally. Right triceps sluggish, left normally elicited. Knee jack, right only flicker of movement, left knee jack normal. Right angle absent, left normal. Plantar mute, sense system normal. So, where is your lock? If you want any clarification, I can show the picture once again.
Facial weakness, sir. Facial weakness.
No facial weakness. Cranials are all normal. Because I did not want to show the entire thing. I can show the lower part I showed that is normal. She can whistle and everything now.
Any local wasting or hypertrophy, sir?
No hypertrophy. Wasting, I could not obviously make it out. This is present from early life.
So long-standing pure motor syndrome, asymmetric.
Correct. Asymmetric, grossly asymmetric.
Grossly asymmetric motor involvement mainly involving the muscles in a patchy manner.
Correct, exactly. Or maybe
Almost for a long time.
Correct, correct.
The beaver sign positive.
Right.
Beaver's positive.
Ah,
And
FSH
Beaver's positive, but abdominal reflex is normal, which means that
Right.
it is not due to the neural origin, more likely to be a muscle origin.
Okay.
So, and since it is a very long time, and she has developed some contracture also, so some of the congenital myopathies should be considered in the first
Okay.
diagnosis.
Right. So that's a good possibility you have to keep in mind. Only thing is a way to diagnose a myopathy, there's three odd things, grossly asymmetrical. Secondly, usually in myopathies pair the small muscles of the feet and hand. Here the small muscles are affected. So that's not totally against. It's a very unusual finding in my even in distal myopathies, they usually tend to spare the small muscles of the hand and feet. That is a classical teaching. They affect the semi-distal muscles. Here the small muscles are also affected. But I agree with you, rest of the all findings are favoring a myopathy positive behavior sign by an anticonceptive only in the lower part is affected. And other muscles are affected almost symmetrically. So I agree with you. Other muscles are also asymmetrically affected. That is again a strong point, not very strong, a typical point for a muscle disease. Even though some myopathies can be asymmetrical, like myositis, anectopathies, and can be asymmetrical. Even Miyoshi can also be asymmetrical. FSH is a classical asymmetrical muscular dystrophy, but he has no facial features. And the distribution of muscle is not in the distribution of a FSH pattern. In fact, I initially thought FSH is one possibility, but the weakness of the small muscle of the foot was little odd. I did not know any I don't know the diagnosis. I also thought some kind of myopathy.
SMA.
So what?
SMA.
The other possibility is SMA, but because the reflexia in the relatively without wasting, reflexia is a point strongly favoring this thing, and against a myopathy within a relatively normal bulk. But there's no, it's again symmetry is also favoring SMA.
Triceps sparing can occur in myopathy, especially sarcoglycanopathy, GMD variants, even though asymmetry.
Yeah, you will think of any muscular dystrophy is possible. I agree with you. Only point is this kind of a distal muscle, small muscle involvement and areflexia. Right angle check is absent, right knee check is absent, the same left side is present. So these things are all little very odd for a myopathic pattern, especially muscular dystrophy pattern. But the nearest possibility is some kind of a muscular dystrophy, correct? Very atypical, odd muscular dystrophy. One which can affect proximal distal muscle is myofibrillar myopathy. But again, this kind of a gross asymmetry is very unusual. Yeah, please, somebody was asked. Yes?
Fatiguability was there.
CMT, the foot will appear like that, but the rest of the findings, behavior sign and all, clear. And the right side, right shoulder muscle is weak, left shoulder muscle is normal.
Any fatigability was there, sir?
Hey, pardon?
Fatigability was there? Fatigability.
No fatigability, no fatigability. Moreover, reflexes are also absent asymmetrically. So, what investigators like to do?
PK first.
These are the two things, muscle disease first, second, Cori-Cori anticonditional disease. So in fact, patient came with an MRI. I don't know why MRI was, that is normal. So what are the blood tests you want to do?
CPK.
CPK. CPK was 1765. So we had certain it's a muscle disease. So anticonditional disease are like. Now what will you like to do? EMG? Okay, EMG is also done. Because some of the anticonditional is also kind of mild elevation of CPK. This little grossly elevated, more favoring muscle disease. So NCS was decreased amplitude that may not be significant. Sensory normal, HPFR robust. So what else you need? EMG. So it is EMG from the affected tibialis anterior. There is no spontaneous activity. Small amplitude potential, brief on potential says you have myopathy. Very good interference pattern. Early recruitment. Read from the deltoid. Again say. Okay, curiously, occasional fasciculations of read from the deltoid. But potential were of small amplitude potentials. These are small, very, very small amplitude potentials. Some of them are large, but most of them are very good interference. So myopathic pattern with some neurogenic potentials. His brother came, neurologist examined, he was normal. What do you want to do now?
Genetic study, sir.
Okay, genetic study. And is the brother examined? I think I'll skip that video in this time because he has no beaver sign. He could get up from the bed without any problem. He could walk on heel and toes unlike his sister. So this is what the genetic test showed. FHL1 myopathy. I don't know, I have not heard of it before. So they say uncertain significance. Okay. Now, if you go back to I looked at literature whether it's could fit in with our patient. Let us see the literature, what literature say. Mutations of FHL1 gene have been associated with a diverse spectrum of X-linked disease affecting skeletal and cardiac muscle. 6 clinically distinct human myopathies can be described and recognized. One, reducing body myopathy. X-linked dominant scapuloperoneal myopathy. Our patient fit with a scapuloperoneal distribution. Scapular muscle is affected, mainly peroneal is affected. X-linked myopathy with postural muscle atrophy, rigid spine syndrome, hypertrophic cardiomyopathy, and type 6 Emery Dreifuss muscular dystrophy. These are the things coming under FHL1 myopathy. There are also a broad range of clinical presentation. Forget about all these things. Okay. Then these are distinct. One is reducing body myopathy, a severe form characterized by progressive muscle loss, weakness, contractures, rigid spine, scoliosis, and scapular winging. Second is X-linked myopathy with postural muscle atrophy, XMPMA, a distinct disease caused by FHL mutation where postural muscle atrophy leading to weakness. Scapuloperoneal myopathy, that is the one which closely fits in with our phenotype, involves weakness of scapular and peroneal muscles. Emery Dreifuss muscular dystrophy, form of muscular dystrophy which features joint contracture, rigid spine, cardiac involvement, rigid spine syndrome. And hypertrophic cardiomyopathy, they affect only the heart muscle. Or patient might fit with couple myopathy same time. So that's only short case. So the lesson I learned was that even myopathy can have small muscle involvement, can have gross asymmetry, can have any pattern, making a total confusion. Initially, I used to teach students when you get small muscles involvement, think of neurogenic pattern neuropathy, unlikely for a myopathy, except GNE myopathy, which can affect. Now we know other muscles also can produce small muscle involvement.
So the reflex loss, how can we explain that, sir? Reflex loss?
I do not know. This is what I obtained. Maybe the only muscle disease reflex was explained by the involvement of the muscle spindles. See, the muscle spindle has got muscle fibers inside the spindle called the interfacial muscle fibers. If those muscle fibers are affected, you can have reflex loss without any extrafacial weakness, muscle weakness, without much weakness. Our muscle contraction is by the extrafacial muscle fiber. They are normal, If intrapersonal muscle fibers are affected early, you can have early reflex loss even in myopathy.
The memory dreyfus will have extensor contractions. Contractions.
Contraction, yeah. But not these are the various phenotypic presentation of FHL1 myopathy. But this our myopathy fits in more with the scapuloperoneal, not the emery dreyfus type. This girl has got contraction of the finger flexors. That I have seen in Miyoshi myopathy, 2-3 cases where kind of finger contraction is in the upper limb without any weakness. So initially thought that is one possibility I also kept. Miyoshi myopathy. After seeing the elevated CPK, but the result came as different. Okay. Shall we close? Any questions?
Sir, I have a question.
Yeah, please.
Good evening, sir. Sir, I
Good
am
evening.
reading something about methylene blue. Does it have any role in neuroprotection or neurodegenerative diseases?
I have absolutely no idea. You have to teach me.
I don't know. So many articles are there. They are telling low dose methylene blue orally can help in mitochondrial function and also in the neural regeneration. And it may be used as an anti-aging. Actually, in skin, they are using it already. Anti-aging, like methylene blue.
Okay. So I think that's a good news for me. Personally, I got a patient with Paul G mutation in my ward. I was thinking we were trying megavitamin I have advised. I think I look into that and advise this methylene blue also to that patient.
I don't know. Please
Yeah,
tell us
I
the
will.
details.
No, I don't know. I'll refer it and tell you. I don't know. I have no idea at all.
Yeah, thank you so much, sir.
Thank you. So, any other questions before we close? Okay, then shall we close?
Okay, sir. Good night, sir.
Okay, good night. Good night.
Good night, sir.
Good night.
Thank
Good
you,
night.
sir.
Thank you, sir. Thank you, sir.
Thank you. Good night.
Good night,
Thank you
sir.
very much, sir. Good night.